Hello, my name is Marcus Green. I'm the Chief Executive of Action on Preeclampsia. We're the UK charity for sufferers of preeclampsia, and we work in three distinct areas. First of all, we offer support to families who have been affected by this condition. Secondly, we work to educate healthcare professionals. And third of all, we're involved in a variety of research across the world to prevent this condition. We're here today on World Preeclampsia Day to recognise the day and to hopefully give some insight and some answers as to what preeclampsia is and why it's important. I'm very grateful to all those people who have contacted us either through Instagram, Facebook, Twitter, or wherever to give us their questions. And I'm really pleased to be able to share them tonight. We've got two experts with us this evening. Professor Andrew Shannon is the Professor of Obstetrics at King's College London. He's based at St Thomas Hospital and is clinical lead of the Maternal and Fetal Research Unit and specialises in clinical trials in antenatal and interpartum care. His research interests include interventions to prevent preterm birth, preeclampsia, encouragement of normal birth, and the use of blood pressure monitoring. He's a keen cyclist and is also chairman of Action on Preeclampsia. Also with us today is Professor Jenny Myers. Jenny is Professor of Obstetrics and Maternal Medicine within the Maternal and Fetal Health Research Centre at the University of Manchester, and she's a consultant obstetrician at St Mary's Hospital. She runs a busy labour ward with 9,000 plus deliveries a year, leads the Diabetic Renal and Hypertension Service, and runs true transitional research clinics for women with hypertension and diabetes. So we've got two very key experts to answer the questions tonight, which I will be asking on your behalf. So the first question, and I think I'll ask Jenny this, who gets preeclampsia?
Okay, well, great starter question, Marcus. I mean, preeclampsia can happen actually in any pregnancy, but it does most commonly happen in women's first pregnancy, but it can happen in subsequent pregnancies. But certainly women in the first pregnancy need to be very alert to the possibility of preeclampsia developing. And in women who've had preeclampsia or other high blood pressure problems during their first or any other of their pregnancies, that is at risk of happening again in future pregnancies. And so we need to make sure that we're watching very carefully. So I hope that answers that question.
Thanks very much, Jenny. So, Andy, what actually causes preeclampsia?
Well, that's a difficult question. We've been trying to work that one out for centuries. So the cause isn't really understood completely, but we're getting better ideas about where it comes from, and it helps us in the management knowing that. So we think it comes really from the placenta, the sort of afterbirth that feeds the baby. And that the problem with that placenta is that it doesn't really take hold of the mother as well as so we say a normal pregnancy. And the reason for that is there's something about it. It is sort of foreign to the mother and is related to the genetics of the mother. And related to susceptibility and so on. So it is quite complicated. And as I said, we don't fully understand it. So the cause goes back to some issue. Now, as Jenny's alluded to, there are some women who get preeclampsia and others that don't. Unfortunately, it's impossible to predict because anyone can get it, even if you have no risk factors. So there are certain risk factors, like if you are more overweight, slightly older mothers, if they have underlying diseases like high blood pressure, so they're more susceptible to it. But also they have to have the wrong placenta, as it were. So it's sort of the susceptible mother with the wrong placenta. And that's kind of related to the cause. So a bit complicated, but we're sort of slowly but surely getting there. So one of the things we've learned, for example, because we know it comes from the placenta, some of the chemicals that the placenta produces in pregnancy actually help tell us who's going to go on and get preeclampsia. So we'll talk a bit later about that, but we now can measure those things even in early pregnancy, and it tells us if you've got a very high chance, or indeed if you don't have a chance of getting it later pregnancy.
Okay. Leading on from that, can preeclampsia be prevented?
So I'll kick off with that, and then I'll let Jenny carry on. So I guess the first thing is the public health issue. You know, women who are more normal weight and are younger and so on are less likely to get preeclampsia. So I guess that's a good message to get out there in general. But you know, the way to manage it is to make sure that you don't miss it. Okay, so that's really the key issue, rather than taking wonderful things to prevent it. So what we encourage when you're pregnant is that you do get all your regular checks and get the blood pressure and the urine checked. Because what matters is really, can you detect it? And then rather than preventing the disease coming, what you're actually preventing is bad things happening once you have the disease, so that you can monitor that woman and you can do things in time, like controlling the blood pressure or even delivery, before there's a serious problem. So when we say prevention, what we're really doing is preventing serious things. Now, having said that, there are some things that have been looked at, and recently we realized that taking a low dose aspirin, if you've got a very high risk of getting preeclampsia, will actually prevent a small number of cases, and seems to prevent the early serious cases. Not in everybody, but in a lot of people. So there are some treatments that can prevent it if you target them. But like I said, the main thing is not to prevent preeclampsia, but actually to prevent the bad things that go along with it.
Okay, thanks, Andy. Jenny, what are the signs and symptoms that women need to be looking out for?
Well, so as Andy says, the most important thing is making sure that women are having their regular antenatal checks with their midwife. So most of that antenatal checkup, having your blood pressure measured and your urine checked for protein, is really the purpose of that is to screen for preeclampsia. And so that's the most, very important message needs to be out there, that women need to be having their blood pressure and urine checked at every antenatal visit. Lots of women with preeclampsia, actually, even when the disease is quite advanced, can actually have no symptoms at all. And that's not uncommon. But there are some symptoms which can develop in women who are developing preeclampsia. So swelling in the feet and ankles is very common in normal pregnancy, but very severe swelling that happens very quickly can be a sign of preeclampsia developing, especially if it's in the face. So quick and rapid increase in swelling can be an important sign that would merit medical attention. And other symptoms that can happen are things like headaches and pain under the ribs, or pain at the top of the tummy, and what we call epigastric pain can sometimes happen in women who are developing preeclampsia. But actually, in the main, lots of women who've got the disease don't have significant symptoms. And so the key thing, as Andy says, is making sure that you're having your antenatal checks and having your blood pressure checked, and maybe, if possible, checking your own blood pressure at home, which increasingly lots of women are doing during their pregnancy.
So leading on from that, Jenny, what if a woman notices some of these signs and symptoms, which on their own can be signs of a fairly normal pregnancy, but coming together, what should a woman be doing if she recognises these in herself?
So I think if a woman, especially in the last third of the pregnancy, develops any signs that they think might be associated with preeclampsia, so things like new headaches, new abdominal pain, new nausea and vomiting, and new swelling, if a woman develops any of those, then we would really urge her to seek some medical or midwifery advice. And that might be a checkup with the midwife, or it might be a phone call to her local maternity triage service to get a check. And so if a woman's ever concerned about developing those symptoms, then getting to a maternity unit or to a midwife to have your blood pressure checked is really the most important thing to get done. And if the blood pressure is normal and there's no sign of protein in the urine, and the check of baby's well-being and everything else is normal, then usually that'd be reassured. And we've now got other tests, as well as Andy's already mentioned, that might help to exclude the condition in that situation.
Okay, thank you. Andy, one of the questions that we get on the APEC helpline very, very frequently is, will preeclampsia happen again? And what are the consequences of having had preeclampsia? So what can you tell us about that?
Well, I think Jenny alluded to the fact that if you have had preeclampsia in the past, you might have a higher chance of getting it again. But actually, even if you've had really early bad preeclampsia, most women are fine. So it doesn't recur in a significant number of people. And even if it does occur, you're sort of ready for it and you can watch for it and act promptly. So the actual outcome is often, you know, better than the previous case. But if you've had it mildly in the past, the worst case scenario is you'll probably get it mildly again. So we tend to worry about people who've had it early and badly. And then we give things like the low dose aspirin to stop it happening again. So it can recur, but actually, recurrence, although that's a kind of risk factor for getting it again, the majority of women won't get it again, and that's kind of very reassuring. We have lots of women who are very terrified about having bad disease in an early delivery, and sometimes they say, I'm never going to have a baby again. And actually, when you talk to them and say, well, actually, it's okay, you'll be watched carefully, you'll be given things to stop this happening again. Now, the other question you ask is, you know, does it matter? Now, the sort of woman who gets preeclampsia may have underlying risk factors that she doesn't know about, like a tendency to getting high blood pressure or other things about her body that puts her at slightly increased risk in the future of things like having, you know, a heart attack or a stroke or something like that. And that is related to how early you get it and how badly you get it, and is your baby kind of small and hasn't grown. However, it's not like devastating. It's not like, oh, I'm going to die young and have terrible disease. It's sort of like having another risk factor. So, for example, when we work out your risk factors for having a heart attack, we put lots of things in, like your cholesterol, your family history, your weight, and this will be another thing you would add into that. And I guess the take-home message is that if you are at risk of these things in future, of having heart attacks and strokes because you've had really bad preeclampsia, look after yourself and make sure you're not overweight and you're not smoking and all those other things. And it's no worse than any one of those things. And there's some things you just can't do about it. Like you can't pick your parents. You can't pick that you've got preeclampsia. So don't be sort of overcome with anxiety that you're going to have lifelong health problems. You're not. But it gives you the opportunity to do those things to look after yourself, to prevent things as you get older.
So if a woman has had preeclampsia, is it sensible for her to keep an eye on her blood pressure long-term throughout the rest of her life and keep an eye on her general health in a way that some women may not? Should it be seen as a bit of an insight into the future and a bit of a warning, Jenny?
Yes, I mean, absolutely, Marcus. I mean, I think that's it. We sometimes talk about pregnancy being a bit of a road test of both your kind of cardiovascular health and also your kind of metabolic health. So the same goes for kind of gestational diabetes as well, that, you know, when these conditions develop in pregnancy, we know that, as Andy's just said, you know, there is an increased risk, and it is an increased risk. It's not a certainty. It's an increased risk of these things happening in the future. And so it's kind of a little alert to just say, you know, you're someone who needs to be really looking after their health, making sure they're having their blood pressure checked regularly, and that might be, you know, once or twice a year. We're not talking about having to check it every day. We're talking about making sure it's being checked once or twice a year, and making sure that if your blood pressure is high, that you're doing things like looking after your diet and lifestyle and exercise. And also, if you have got high blood pressure, having that appropriately treated, because, you know, hypertension, high blood pressure is very treatable, and nobody wants to be on you know, pills, but, you know, there are pills which are very effective with, you know, very good side effect profiles, you know, aren't going to bother people too much, that can treat the blood pressure and keep people safe in the long term. So it's about being aware and being alert to those and accessing the right health going forward, rather than, Andy says, as being terrified that this is a, you know, a terrible thing that's going to happen in the future. Be active and proactive, and you can prevent it from happening in the future.
And I think, Marcus, just to add to that, you know, if you're destined to have a stroke in your 50s or 60s because of high blood pressure, people don't know about it during their 30s and 40s, and that is when the treatment will make a difference. So in a way, you can say, well, actually, pregnancy's revealed this to you and an opportunity to do something about it. Whereas, you know, the blokes don't get that. You know, they just sort of turn up with their strokes and think, gosh, I wish I'd treated my blood pressure for the last decade. So in a way, you know, this is a sort of opportunity to kind of help yourself.
Yeah, that's great. Now, we get a number of calls on the helpline from women and from partners of women who've just been diagnosed with preeclampsia. And it's a really simple question. Am I going to be okay? What are the treatments? How do we look after people at the moment?
So maybe I can start with that. I mean, we look after people when they've been diagnosed with preeclampsia by watching things very, very carefully. And I call it, you know, a top to toe assessment that we do every time a woman comes. So for example, today I've seen 3 or 4 women who've got a diagnosis, 4 women who've got a diagnosis of preeclampsia, and I've assessed them. So I've assessed how their blood pressure is. They're all doing their blood pressure monitoring at home, and they're taking their tablets, and they're looking after their blood pressure very carefully. I've checked to see if they've got any symptoms that have changed from the last time I've seen them. So the symptoms that we talked about before. I've assessed the baby by doing the necessary monitoring of the baby. That might be a scan, that might be heart rate tracing. It might just be listening into the baby. And we've usually done some blood tests, which we do usually 2 or 3 times a week to check for any changes in the body that might be related to the preeclampsia. And then when I see any indication that those assessments, that top to toe assessment is starting to change, then as Andy says, then we have to start thinking about talking about delivery, and because when we deliver the baby, the preeclampsia will start to get better. And so every time I see a woman, we're assessing, is that baby and is that mother safe for us to continue the pregnancy, or are we putting the mother and baby at risk by continuing the pregnancy, in which case we need to think about delivering the baby. Now that's straightforward if the pregnancy is in the last few weeks of the pregnancy. That's a more straightforward kind of question and a more straightforward discussion. Clearly that's a much more difficult discussion when the pregnancy is very premature, and that's where this condition has its devastating consequences sometimes, because we do sometimes have to deliver babies very, very prematurely.
Just to add to that, Marcus, you know, when you say, will you be okay? Actually, you always hear the bad stories, don't you? You know, I died from preeclampsia, or my baby was born early, or whatever. Actually, the vast majority of people who get preeclampsia are absolutely fine. It tends to be late, it tends to be mild. It's actually frightening, but an inconvenience, because you might have to be delivered a bit earlier, but you end up having a normal labor, a normal delivery, your baby's fine. What matters is you don't miss it. So the problem is that if you don't know about it and you don't, you know, what you need is to be under the care of Jenny, who will pick up when there's a problem and do something about it. You'll be absolutely fine. But that's why these checks are so key. You know, you mustn't miss it. But the vast majority of people are absolutely fine. In fact, in this country, in the UK, we're very, very proud of the fact that we have one of the sort of best outcomes for mothers in the world because of our National Health Service. People aren't missed. And when they're not missed, they do incredibly well. There are always the odd, very rare case where a baby has to be delivered very early, and that's not good for the baby. But the mothers, it's incredibly rare to die now from this disease because of this care.
Yeah, that's interesting. You've talked very much about the woman and what she can do, and you've talked vaguely about tests. Now, I know that there is a new test, placental growth factor testing, PLGF testing, and it's becoming increasingly well known, but I don't think people understand it terribly well. Jenny, you're nodding your head. Perhaps you'd like to start on a bit of an explanation on what this is all about, and what other tests do you have that are available in your armoury?
Yes, so up until, you know, a few years ago, we diagnosed preeclampsia, you know, with a change in the blood pressure. We looked for other signs that this condition was starting to affect other parts of the body. So we looked for protein leaking in from the kidneys into the urine, and we looked for some of the blood tests, which can happen in quite extreme cases of preeclampsia and indicate that the disease is starting to progress. But now we've got a new test which actually measures some hormones or chemicals produced by the placenta. Andy mentioned, this is a condition that's caused by, you know, usually a kind of damaged placenta, and that sends out what I call distress signals into the maternal system, and we can now measure some of those distress signals as these abnormal levels of these chemicals or hormones or proteins in the maternal blood, and they allow us to detect that placental problem often much earlier than we used to. So we can often now identify that there's a problem and that preeclampsia is developing often before the woman's actually develops even her very high blood pressure or the protein leaking into the urine. And so really importantly, when we diagnose the condition using this blood test, it doesn't mean that we need to deliver the baby. It doesn't mean that we need to leap in. It just means that we need to watch that woman really, really, really carefully to detect any signs that the disease is progressing at the point where we would need to deliver the baby. The flip side of using the test is that it's even more useful in ruling out the condition. So what it's really, really useful for is saying, okay, the blood pressure's changed a little bit. What's going on here? Is this a normal change of pregnancy, or is this preeclampsia? And we can do the PLGF-based test. And if that PLGF-based test is normal, we know that the chance of that lady developing preeclampsia or any consequences of preeclampsia in the next 2 weeks is really, really low. So we can reassure the woman and her family, and we can return her back to her normal or her midwifery or hospital surveillance, whatever was already in place, and we can reassure her that everything is well. So it's really transformed the way that we risk assess or what we call stratify our care and surveillance for women who present with blood pressure, which is a very common problem in pregnancy. 1 in 10 women during pregnancy will have a raised blood pressure at one point or another. And so it's really important that we work out amongst that 1 in 10 women who are the women who are developing preeclampsia and need really careful, close surveillance and monitoring.
Is there anything you'd like to say about that?
Yeah, I mean, I have to say, I find the test amazing. It really helps the women. And as Jenny alludes to, telling you that you're okay is worth a lot, because we're all terrified of this disease because very rarely it is incredibly serious. And so we take it seriously, quite rightly. And so you tell women, you might have a serious problem, you need these tests, you might need to come into hospital, we don't know what's going to happen. And it's very scary for them. But a huge number of them are absolutely fine. So instead of sort of sitting there worrying, won't I be delivered? Have I got a serious problem coming? Am I going to be delivered early? You literally know almost in minutes, and you can say, no, you're fine, go away, rather than sit people on wards for days. So actually, it's been a real kind of advance for us, I think, in recent years to be able to do that.
So you say that for women, you might actually be, if you suspect they've got preeclampsia in times gone by, you might have whipped them straight into hospital, kept them there for a while, and now you can say, no, go back to your normal everyday life. We're going to keep an eye on you, but you've got nothing to worry about in the short term. And that's a great advance, isn't it?
Yeah, absolutely.
And the managers love it because it saves them money. We keep people in the hospital. It's a win-win-win.
That's kind of important. Now, we've had a number of questions.
It's important when you want to introduce something into the service, yeah.
So, PLGF testing, is that available everywhere or not yet?
Not yet, Marcus, unfortunately, and it's available in England, and we're working hard, and APEC have done incredible work trying to get the message out there in terms of helping to roll out the test to devolved nations and further afield. It's available in some places in Europe. It's not available in the US, incredibly. So, there's a lot of work to be done. But in England, we're really fortunate that we've been able to roll that out, and that's been thanks to a lot of research that APEC has helped to support and deliver.
This sounds like an advert, doesn't it? Reassure everyone we actually love the tests. We're not advertising anything. Actually, there are a number of these tests available from a number of different companies, and because they are cost saving, paying for them makes a huge difference. And none of us have shares in them, so we genuinely think this is a great advance. Yeah.
Yeah.
Okay, well, let's park PLGF testing then for the time being. And I want to move on to one of the complications, as it's traditionally called, of preeclampsia, which is HELLP syndrome. Jenny, can you fill us in on what HELLP syndrome is? I've had a message from Rachel. She says that she had HELLP syndrome, but it wasn't accompanied by preeclampsia. She was really unwell, multi-organ failure. Her blood pressure was never overly high. And it only got very high when she was in intensive care. What's the likelihood of it recurring? What is it? What is this all about?
Okay, so there's lots in that question, and I'm not going to be able to go into lots of detail this evening. But HELLP syndrome is a variant. It's a severe end of the spectrum. We usually think of it in the condition that is preeclampsia. So, as Andy said, preeclampsia for most women is a mild condition, doesn't cause any changes in the other organ function. But in some cases of preeclampsia, you can get these very severe complications, which HELLP syndrome, eclampsia is another very severe complication associated with preeclampsia. And what basically happens is that the organs get disrupted by these chemicals that are abnormal in the blood. And we start to see problems with the liver. So the function of the liver starts to deteriorate. We see changes in the way that the kidneys work, and we see changes in the way that the blood clots. So there are some cells in the blood called platelets that are responsible for controlling the way your blood clots, and they can become activated and behave very abnormally. So it's a rare and very severe variant of preeclampsia, which can cause, in severe rare cases, multi-organ problems, multi-organ failure, and require intensive care.
Okay. We seem to have lost Andy, so you're in the hot seat, I'm afraid, for the next couple of questions.
Okay.
And again, it's about HELLP syndrome. What are the signs and symptoms that people should look out for specifically for HELLP syndrome?
So as I said before, when we're reviewing women who've got preeclampsia, one of the things we're doing is looking for these severe multi-organ complications all the time. So we kind of make our diagnosis and we explain to the woman, you've got a diagnosis of preeclampsia now, and we need to monitor very carefully for signs that preeclampsia is starting to affect your baby's health or your health. And when I say when the preeclampsia might affect your health, what I'm checking for is that the liver function is working normally, that the kidneys are working normally, and that these platelets are functioning normally, and they're not being, that the platelet count's not being reduced. And if we see evidence that those things are starting to change, then that starts to point towards this development of multi-organ involvement. And so our job is to act before that becomes multi-organ failure in the setting of HELLP syndrome. Unfortunately, and this may have been the case with Rachel, but unfortunately in cases of HELLP syndrome, sometimes it can come on very, very rapidly. And I do see women, as do all of us who look after women with preeclampsia, we do see women who go literally 0 to 60, in a matter of hours. Now that's quite rare, but it can happen. And so sometimes we see things happen a little bit out of the normal sequence of events. So instead of the blood pressure developing first, then the protein in the urine, then the change in blood tests, unfortunately, in some situations, all of that happens in one go. And we see those very severe organ involvement happening. But maybe before we've seen the big changes in blood pressure, and that is an atypical, but that does happen. That sort of atypical and rare presentation of preeclampsia and HELLP syndrome.
We've got one final question from Lucy. She said that in her first pregnancy she had preeclampsia and HELLP syndrome. The baby was delivered at 28 weeks. Second time around, she wasn't diagnosed with preeclampsia, but she took aspirin to begin, then labetalol as the blood pressure increased dramatically, and her waters broke at 28 weeks. And she had placental abruption at 30 weeks. Now, is there a connection between preeclampsia and placental abruption, or is this a total coincidence?
I can take that. I'm sure Andy will have comments as well. So again, placental abruption is another one of the complications and severe consequences that can happen with preeclampsia. Now, placental abruption can happen in women who don't have preeclampsia, but it can happen in women who've got preeclampsia, and actually it's one of the complications that can happen during preeclampsia that we worry about. Again, it's rare and uncommon, but one of the problems with abruption is that it can come a little bit out of the blue. And one of the reasons that we offer very close surveillance and intervention for women with preeclampsia is to try and reduce the risk of an abruption happening. So the two conditions are associated, but abruption, fortunately, is uncommon even in women who've got preeclampsia.
Okay, welcome back, Andy.
Yeah, sorry, this is sort of the beauty of working at home, isn't it? Wi-Fi comes and goes. Sorry, I missed the HELLP syndrome question, but actually abruption is like just another variant that's rare. And if you take 100 women with preeclampsia, only about one of them is going to have an abruption. And even if they do, if you're in hospital and being monitored closely, you can deliver that baby safely most of the time. So yes, it is associated, and it's more common in women with preeclampsia than in other conditions. But it's the same old problem. The placenta comes away. The preeclampsia is disease of the placenta, and it makes complete sense that sometimes abruptions will happen, but they are rare, and they're a sort of serious version of it, a bit like HELLP syndrome or having a fit or something like that.
Well, I think over the last half an hour or so, we've covered just about all of the main questions that people might have about preeclampsia, about HELLP syndrome. We've looked at what people should be looking out for, and how people can get on to make life a bit easier for themselves, both during their pregnancy and later on in life. So I'd like to say thank you very much to both of you for your time this evening. We'll finish the webinar here, but there'll be a slide afterwards which has got all our web links and how to get in touch with Action on Preeclampsia. And if we can be of any help, please do not hesitate to get in contact with us. So to everybody who's joined us this evening, thank you very much. And we look forward to hearing your questions in the future. So thank you. And thank you, Andy, and thank you, Jenny.
No, thank you, Marcus. Take care. Have a nice evening. Bye-bye,
Thank you.
everybody.
Cheers. Bye.
Bye. Bye-bye.